everybody. I'll be speaking in general about the management of univentricular heart. Actually, it's a very big topic, and each small thing in this should be talked in detail. It's like this, but I'll just give you a brief idea about what are the basic principles of management of univentricular heart. When we consider that univentricular heart management is required, what are the limitations and how they need to be evaluated properly. So this is in general, I'll be talking about the management of univentricular heart. So, yeah. So what is the surgical definition of a univentricular heart? When do we call that that heart cannot undergo a biventricular repair? When there is an inability to establish two independent functioning ventricles to support in series. So we have two ventricles, and if you are not able to support them in series, we call them as a surgical definition wise a univentricular heart. And there can be multiple variants when we are not able to establish two functioning ventricles to support. One is that I'll give you an example when we call this as an independent variant. One is the inadequate ventricular size and ventricular volume. You know that which is very obvious in patients with hypoplasia of any of the ventricles, either the right ventricle or left ventricle. And second is lack of independent inflow. So always you remember that ventricular size and volume is depending upon the inflow. So inflow usually determines the size of the ventricles, because the inflow that is either a mitral or a tricuspid valve, and therefore when you know that when we take the echocardiographic measurements, we take the annular size of either of the valve, see the z-scores. And if the z-scores are usually less than -2, or in some situations less than, especially in tricuspid valve, less than -4, we say that the inflows are inadequate. And usually, as I told you, that inflows determine the ventricular size. So tricuspid valve inflow determines the right ventricular size, mitral valve inflow determines the left ventricular size. And therefore, when we do the echocardiographic assessment, the adequate assessments of the ventricular inflow and correct them with the z-scores, they are one of the major important determinants to detect or determine the ventricular adequacy of the ventricular size and ventricular volume. So one is inadequate ventricular size and volume, lack of independent inflows. One is either hypoplasia or lack that you have a mitral atresia or you have tricuspid atresia. Automatically your ventricles are not going to be normal. Secondly, you are not able to connect the inflows to the ventricles, and you may not be able to establish two functioning single ventricles. And the third thing, inability to establish adequate left ventricular outflow. And that is the example of hypoplastic left heart syndrome. So surgical definition wise, hypoplasia of either of the ventricles, lack of independent flows, and inability to establish adequate left ventricular outflow. And in this third situation, in addition to hypoplastic left heart syndrome, you know we have entities called as a double outlet right ventricle with the VSD, which is in a location where you may not be able to establish a good left ventricular outflow. And especially in double outlet right ventricle or sometimes in transposition situations, your VSDs are in such a location that your LV to aorta connectivity will not be possible. And those kind of a VSDs, even if you have two good ventricles in that situation, your VSD is the only outlet for the aorta, and those VSDs may not be suitable for a LV to aorta tunneling. So in spite of having two good ventricles, a two ventricle repair is not possible. So these are the surgical definitions or a surgical subsets where we need to consider a univentricular repair. Now you know anatomic variants. As I said, tricuspid atresia, a commonest ones I am telling you don't have a LV inflow. You have unbalanced AV septal defects with one ventricle which is hypoplastic. So you have a single AV wall and the wall attachments are such that one of the ventricles is hypoplastic and therefore you may not have two good size adequate ventricles. Third is double inlet ventricle, that you have two AV walls, but the VSD is such a large that functionally it is like a single ventricle, and you may not be able to parted that ventricle to create a two ventricle repair situation. The fourth one is, as I said, it's a double outlet right ventricle with a remote VSD. So you have two good ventricles, but your left ventricle through the VSD cannot be routed to the aorta. In spite of having two good ventricles, in the plastic left heart syndrome situations, you have a mitral atresia or hypoplasia, small size left ventricle, small size aorta. The subset is a future single ventricle repair. Pulmonary atresia, intact ventricular septum. Actually, that is a like a severe most form of tricuspid atresia. So pulmonary atresia, intact ventricular septum, again many times it is associated with hypoplastic tricuspid wall and hypoplastic right ventricular cavity, and many times this subset also go for a future univentricular repair. A very small subset in this subgroup of pulmonary atresia, intact ventricular septum, if you have a good tricuspid wall and a good right ventricular cavity, may be feasible to go for two ventricle repair, but in general, this variety also has a lot of abnormalities of the tricuspid wall. So again, go back to the previous slide. Inadequate ventricular size and volume, as we said, in unbalanced AV septal defects, you don't have two good size ventricles, lack of independent inflows, abnormalities with the tricuspid wall or a mitral wall, inability to establish adequate LV outflow that goes in either a hypoplastic left heart syndrome or a double outlet right ventricle or a transposition with remote kind of a VSD, where in spite of having two ventricles with good size ventricle size and volume, we are not able to do a good biventricular repair. So now one is now, these are surgical definitions, these are anatomic variants for single ventricle, and now what are physiologic variants? Sometimes you have balanced circulation. So now we define anatomically that these are single ventricle repairs. So what are the physiologic variants? You have balanced circulation. That means you have a double inlet left ventricle or a single ventricle with a moderate to severe pulmonary stenosis. And many times you see these patients come to your outpatient clinic, they are little grown up. Their saturations may be around 80–85%, they are asymptomatic. So it's sometimes very perfectly balanced circulation. So saturations are okay, the pulmonary circulation is just adequately protected, they are barely symptomatic. And many times you see them later in the life because it's a mildly protected pulmonary circulation, and suddenly you just find them are becoming symptomatic in their late 10s or 15 year of age group, and this is called as a balanced parallel circulation. Now the second variant is significantly reduced pulmonary blood flow that you see with severe cyanosis. Now that you see as an inadequate pulmonary blood flow or significantly obstructed pulmonary blood flow. Now what is inadequate pulmonary blood flow? You have a typical example of pulmonary atresia, intact ventricular septum. The pulmonary circulation is PDA dependent, which may be completely inadequate. And therefore, this is a kind of a single ventricle situation with significantly inadequate blood flow. The second one is significantly obstructed blood flow. The simple example is a tricuspid atresia, severe pulmonary stenosis. You know, the pulmonary stenosis or obstruction to blood flow in tricuspid atresia is mainly at the VSD level. So your VSD is significantly restricted. That causes obstruction to the pulmonary blood flow. So the typical example in our clinical practice is tricuspid atresia with severe pulmonary stenosis is an obstructed pulmonary blood flow. So either a balanced circulation, the second one is a significantly reduced pulmonary blood flow. Now the third one is a significantly increased pulmonary blood flow. You see a single ventricle who comes with congestive heart failure. Very typical presentation of a univentricular heart with excessive pulmonary blood flow. Your oxygen saturation is around 90%. They are in congestive heart failure. The typical example is double inlet left ventricle, transposition of great vessels with no pulmonary stenosis. Very typical example. The second one can be unbalanced AV septal defect without pulmonary stenosis. So you have unobstructed or excessive pulmonary blood flow. And the second one is a obstructed systemic blood flow. Again, the typical example is hypoplastic left heart syndrome. Your systemic blood flow is significantly obstructed. In that situation also, when you have a hypoplastic left heart syndrome, on one side your systemic blood flow is obstructed, on the other side you have an excessive pulmonary blood flow. And the last one is a ductus dependent systemic circulation. Again, it's a classic example is a hypoplastic left heart syndrome. In obstructed systemic blood flow also you have some kind of a varieties when you have a double inlet ventricles with significantly obstructed bulboventricular foramen. So you have obstructed systemic blood flow in that particular situations also. So as far as the physiologic variance in single ventricular or univentricular heart, as I said, one is a balanced parallel circulation. Just adequately manage without symptoms and your pulmonary blood flow is protected. You have significantly reduced pulmonary blood flow with severe cyanosis. You have excessive pulmonary blood flow who come with heart failure, and you have a ductus dependent systemic circulation. Remember, these are the four physiologic variants in patients with univentricular heart. You have anatomic variants where you have to define what kind of anatomic substrate these patients lie into. These are physiologic variants which really determine the clinical presentation of these patients. Now, what is the general approach? When we see a patient with single ventricle, it can be anything. It can be tricuspid atresia, double inlet ventricle, pulmonary atresia, intact ventricular septum, or unbalanced AV septal defect. You have a patient with a single. Now, when we try to see this patient, first determine whether it's a two ventricle situation or a single ventricle situation from management point of view. Now, once you rule out that the patient does not fit into a two ventricle parallel circulation or serial circulation, now rule them out. Now come to a single ventricle situation. It can be any of an anatomic variant as we discussed. Now, how do we approach now? We have a patient with tricuspid atresia or unbalanced AV septal defect. Now, what will you do? How will you approach? The whole line of management you have to maintain, because this is a kind of a subset which all the long-term outcomes, they depend upon your pulmonary blood flow, pulmonary artery sizes, pulmonary artery pressures, your competency of the AV valves, your left ventricular end-diastolic pressures, your pulmonary venous return has to be good, because any kind of this change in this physiological circulation is going to affect the long-term outcome of a single ventricle. And each of these variables is very important. And therefore, you have to, even if the patients sometimes are relatively asymptomatic, you have to act appropriately at appropriate time and age of the patient. Because if you just leave them alone for some period of time, suddenly you will see their AV valve is leaking. You suddenly see the ventricles are dilating, your LV function is not great. These kind of situations can be easily tackled when you have two ventricle situation. But when you are managing a single ventricle situation, each of these parameters is very important, and that needs to be addressed at proper age and proper time. And therefore, you need to be very clear that what are we looking at when we look at a management of a univentricular heart. The first one is maintain adequate systemic perfusion, hemoglobin and oxygen saturation. The second one, we have to maintain normal ventricular function, and therefore the whole attempt has to be prevention of ventricular dilatation and hypertrophy, because we know that we have to take them for a future single ventricle repair. If your ventricle start dilating or ventricle starts becoming hypertrophic, especially as I said, you have a restrictive bulboventricular foramen, it causes your subaortic obstruction. Your LV and diastolic pressure keeps on going up like 15, 20. They don't become suitable candidate for a Fontan completion or for a single ventricle repair in future. So it's very important from the beginning, see to it that we have to prevent ventricular dilatation and hypertrophy. At some period of time, we know that we have to establish a systemic venous to pulmonary and artery connection, and we have to prevent and control the arrhythmia. So this is in general approach when you see a single ventricle, and we have to do the subsequent surgeries, because we know this is a palliation. It all depends upon or works on your pressures, anatomy, resistance. So we have to keep all these physics parameters perfect. Then only the circulation is going to work. What are the indications for very early intervention? So usually we know whether we need to intervene in early neonatal life in patients with a univentricular heart. So what are the indications where you really have to intervene in the early neonatal life? You have systemic outflow obstruction. Get an example of a hypoplastic left heart syndrome. You have a systemic outflow obstruction. You have a mitral wall abnormalities, you may have aortic stenosis, aortic atresia, you have hypoplasia of the aortic arch or interruption. So there is a systemic outflow obstruction. In addition to systemic outflow obstruction, especially in patients with hypoplastic left heart, if you don't have adequate blood flow in the ascending aorta, your coronary perfusion is also at risk. So systemic outflow obstruction in patients with hypoplastic left heart syndrome is an early indications to intervene immediately after birth. The second one is severe cyanosis. You have patients with pulmonary atresia intact septum or tricuspid atresia, pulmonary atresia, severe cyanosis. You have to intervene very early because you have to release cyanosis. The third thing, you have an excessive pulmonary blood flow. That means you have a double inlet ventricle, no pulmonary stenosis. You have excessive pulmonary blood flow. The second thing is you have a unbalanced AV septal defect. The ventricle, one ventricle is small, other is large, with severe pulmonary artery hypertension. So they will be symptomatic because of increased pulmonary blood flow. And the fourth important thing, especially in patients with heterotaxis syndrome, you have obstruction to the pulmonary venous return. So usually in general, the long-term prognosis of patients with a single ventricle with a CAPVC which is obstructed may not be very good, mainly because the pulmonary vascular resistance may remain high for a very long time. And then it may not be suitable for a future single ventricle repair because your pulmonary artery pressures are high, your pulmonary vascular resistance may be high. And these kind of a patients, we need to intervene very early in neonatal life or maybe in early infancy. And I'll tell you how do we do that. So remember, you have a systemic outflow obstruction, like in patients with hypoplastic left heart syndrome. You need to relieve the systemic outflow obstruction. You have severe cyanosis in patients with tricuspid atresia and pulmonary atresia or pulmonary atresia intact ventricular septum. You have excessive pulmonary blood flow, like in patients with double inlet left ventricle without pulmonary stenosis, and obstruction to pulmonary venous return. So these are the four categories where you need to really intervene them. Some immediately afterwards, like hypoplasia, you have to work on immediately afterwards. You have severe cyanosis of pulmonary atresia intact ventricular septum, first few days. You have obstructed TAPVC in addition to a single ventricle. You have to act immediately after birth. Maybe for increased excessive pulmonary blood flow, you may wait for maybe a couple of months. But these three, systemic outflow obstruction, severe cyanosis, duct-dependent pulmonary circulation, and obstructed pulmonary venous return, they need intervention maybe in first few days of life. Now, management plan-wise. As I said, initial palliation, maybe you don't know at what time. Maybe, as I said, if you have obstructed pulmonary venous return on day 1, if you have a significantly reduced pulmonary blood flow, as it's tricuspid atresia, pulmonary atresia, or tricuspid atresia with severe pulmonary stenosis and your saturations are very low, and they have significantly reduced pulmonary blood flow, they may need a aortopulmonary shunt or a ductal stent, whatever it is to improve the pulmonary blood flow. You have excessively high pulmonary blood flow like double index ventricle without pulmonary stenosis with increased pulmonary blood flow. Usually they need an early pulmonary artery band, and we do pulmonary artery band. It's a generally preferred practice by around 2 to 3 months of life, because we have to get the pulmonary vascular resistance down, neonatal pulmonary vascular resistance down by 4 to 6 weeks. And after 6 weeks, usually it's the ideal time to do a pulmonary artery band, unless they have any additional issues like systemic outflow obstructions or pulmonary venous return is the issue. Then they will need a surgical intervention very early. But if you just have a double inlet left ventricle without pulmonary stenosis, with excessive pulmonary blood flow, by and large, pulmonary artery band is preferred after 6 to 8 weeks of life. And we know that then we go for a definitive palliation beyond. Usually the Glenn shunt is performed between 6 months and 1 year of life, and Fontan completion by 5 to 6 years, and it all depends upon the institutional preference and their practices. And as I said, these are the different varieties how we do it. Sorry. And in addition, in some of the patients, in addition to pulmonary artery banding, they have to do some additional procedures. I'll give an example of mitral atresia, very restrictive AST or very intact interarterial septum with severe pulmonary, excessive pulmonary blood flow with the pulmonary artery hypertension. So in this situation, doing a wide atrial septictomy is very important, because we know mitral atresia, nearly intact interarterial septum, your pulmonary venous pressures are going to be very high. So in addition to reduction in the pulmonary artery blood flow, it's very important to have a very wide interarterial mixing. So in these patients with mitral atresia, we have to see to it that, and the same thing is about the tricuspid atresia, we need to have a wide interarterial communication, especially if we have to reduce the pulmonary venous hypertension and to increase the pulmonary vascular resistance. So these kind of additional procedures are also required to, in addition to this other palliative procedures. And I'm just showing you some of the examples. Now you see here very clear cut. We have tricuspid atresia, mildly dilated ventricles. You see the interarterial septum is bowing onto the left side. So these are actually subtle things we need to pick up on echocardiography. You see your right atrium is dilated, your interarterial septum is bowing. That tells you that your interarterial communication may not be good. And these kind of a patient, and the same thing can happen in mitral atresia, when your interarterial septum may be completely bowing onto the right, telling that your left atrial pressures are high. So in these situations, when you do the palliative procedures like either a shunt or a band, you need to do a wide atrial septictomy to have a wide interarterial communication. I think some of my pictures may not be seen well, I don't know that, but I'll just try. This is another example that you see a very hypoplastic left ventricle. It's a mitral atresia, a variant of hypoplastic left heart syndrome. So this is another example of a hypoplastic left heart syndrome. And here I tell you, see, this is a variety where you have a significantly hypoplastic aorta and hypoplastic aortic wall, a variant of hypoplastic left heart syndrome. So early surgical palliation neonates, as I said, either you require a shunt or a stent, a pulmonary artery banding, plus or minus repair of systemic outflow obstruction. Now, what is this repair of systemic outflow obstruction? Again, a classical example is hypoplastic left heart syndrome where you have to do a DKS. Sometimes you may have other variants of double inlet left ventricle where you can't do pulmonary artery banding if you have a restrictive bulboventricular foramen and you expect that if you do a pulmonary artery banding, there is a possibility that you can create a subaortic obstruction. So that needs to be evaluated very carefully, and I think if you go to this book of Rebecca Schneider, how do you assess a double inlet left ventricle and how do you assess the adequacy of the bulboventricular foramen? It's a very important thing, and there are multiple parameters which have been given in as to the size of the aorta and the size of the bulboventricular foramen. Because after you do a pulmonary artery band, if your bulboventricular foramen starts restricting because of the hypertrophy of the coronal septum, you will create a subaortic obstruction. If you create a subaortic obstruction, your LV is going to hypertrophy and your LV and diastolic pressures are going to be high, and that is not going to work as a long-term single ventricle repair. So it's very important to see when you do a pulmonary artery band, you are not creating a systemic outflow obstruction or a subaortic obstruction. And those are all the situations where you can't just do a pulmonary artery band, but you have to do a procedure called as a DKS. You have to connect the aorta to the pulmonary artery, you transect the pulmonary artery, and either you do a aortopulmonary shunt or you do something called as a Sano shunt, where it's a shunt between the right ventricle and pulmonary artery. So when you do a pulmonary artery banding, repair of the systemic outflow obstruction is very important. And another thing, in patients with hypoplastic left heart syndrome, you may have aortic arch abnormalities, hypoplasia or interruption. You have to take care of that. In addition, if you have a pulmonary venous return which is obstructed, as I said, in patients with heterotaxy, you have a univentricular heart with an obstructed pulmonary venous return with excessive pulmonary blood flow. So you can't just do a pulmonary artery band, you have to relieve the pulmonary venous obstruction. And as I said, in third one, if you have a patient with mitral atresia with a very restrictive ASD with excessive pulmonary blood flow, you can't just do pulmonary artery band, you have to do a wide arterial septectomy. Otherwise, your pulmonary venous pressures will be very high, pulmonary vascular resistance will go high, and they won't be suitable candidates in future for univentricular repair. So in early neonatal life, you have to do a systemic to pulmonary artery shunt if they are very cyanosed or has pulmonary atresia. In patients with excessive pulmonary blood flow, we have to do pulmonary artery banding. But see to it that your systemic outflow is unobstructed, your pulmonary venous return is good, and you have a wide interarterial communication if one of your AV wall is narrow or obstructed. If you have a double inlet ventricle, you have a normal two AV walls, you may not need to do a wide atrial septectomy because your AV walls are unobstructed. You have to do a wide atrial septectomy if one of the AV wall is small or obstructed, and that is a mandatory management pattern. Sometimes, sorry. So I just wanted to show you some of the examples where this is a patient with a severely obstructed pulmonary blood flow, confluent pulmonary arteries, and how the flow. What I'm trying to tell you about the bulboventricular foramen, this is a double inlet ventricle. And you know, double inlet ventricle usually have transposition of great vessels. Your aorta comes from the hypoplastic ventricle, your pulmonary artery comes from the main ventricle. Now, you see this is a coronal septum. This is your bulboventricular foramen. and assessment of adequacy of the bulboventricular foramen in patients with a double inlet ventricle is a very important thing, because if you do a pulmonary artery band here, your corner septum gets hypertrophic. When your corner septum gets hypertrophic, your bulboventricular foramen starts getting restricted. Your aorta is coming from here, and you may cause subaortic obstruction. So assessment of adequacy of bulboventricular foramen in univentricular heart is a very important thing on echocardiographic assessment. And as I said, you go to Rebecca Schneider books, all these formulas are written, and you have to assess this bulboventricular foramen in multiple views, so that you have, it's only a one dimension, but you have to see this bulboventricular foramen in multiple directions, and there should not be any flow acceleration, because the moment you put a pulmonary artery band, your corner septum is going to hypertrophy, and you're going to create a subaortic obstruction. And in this kind of a situation, you need a decay. So you have to translate the pulmonary artery. You have to connect the aorta and pulmonary artery here, like a AP window correction, and have a additional aortopulmonary shunt. I don't know whether it will work, but this was a patient where I wanted to show you that there was an obstruction to the bulboventricular foramen and needed a aortopulmonary. This is needed a selection. Now this, as I said, I was showing another restrictive interatrial septum. You need to do a wide atrial septectomy in the first stage itself. Now your second stage, either a bidirectional Glenn, or sometimes what they do is a hemi-Fontan. You know, hemi-Fontan, what they try to do, they try to close the roof of the right atrium and disconnect the SVC from that side, that end itself. So it is easier to complete the Fontan in the next stage. Sometimes, if possible, if you have a patient with tricuspid atresia, pulmonary tricuspid atresia with severe pulmonary stenosis, and then suddenly comes to you at 5 years or 6 years of age, and it's not very uncommon with us, they can directly undergo a completion Fontan at that particular age. But usually after the first stage, the second stage is either a bidirectional Glenn or a hemi-Fontan, and as I said, usually we prefer to do it by 6 months to 1 year of age, just to unload the left ventricle. Now this is one of the very, very important steps, because it's a cavopulmonary anastomosis, and as I said, everything will depend upon your sizes, flows, resistances. So we have to see that your SVC will flow properly into the pulmonary artery, and for that, evaluation of the pulmonary artery bed is the crux in patients with single ventricle repair when we try to do a bidirectional Glenn. We have to assess the pulmonary artery anatomy by whatever means. If you are okay, sometimes some centers may be happy just doing echocardiography, but many centers prefer to have another imaging or maybe even cardiac catheterization prior to a bidirectional Glenn if you have any other issues. Especially if you have any palliated heart, that if you have either a shunt or you have a band, or it's definitely after a DKS repair for hypoplastic left heart, it's mandatory to have a cardiac catheterization to see all these variables, whether they are suitable for a bidirectional Glenn. So the first one is pulmonary artery anatomy. Second is assessment of pulmonary blood flow. I think it's very important to have a QP/QS calculated, especially if you have a pulmonary artery band or a shunt prior to Glenn. What are the systemic venous anomalies? Whether you have a IVC interruption with azygous continuation, because if you have a IVC interruption, they will go something called as a Kawashima repair. So all the SVC flow and most of the IVC flow, except the hepatic venous blood flow, will go into the SVC while doing a bidirectional Glenn. Whether you have a single SVC or two SVCs, bilateral SVCs, what is the level of AV wall regurgitation, and whether that needs to be addressed while you do a bidirectional Glenn. Are there any additional aortopulmonary collaterals, whether they need to be embolized? And as I said, site of the interventricular communication, usually we see it in the first stage itself, but again, reevaluate if you have any kind of a doubt if you just have done a pulmonary artery band and your bulboventricular foramen has become restrictive. So we need to see all those variables very correctly when we do a bidirectional Glenn. So these are very, very important variables, and as you know, you must be reading all the Joseph's criteria or 10 commandments. But amongst all those things, what are the most important commandments is the pulmonary artery anatomy and pulmonary vascular resistance, and in addition, a left ventricular and diastolic pressures. Again, we need to, as you know, there are 10 commandments. You have to see the atrial arrhythmia, systemic pulmonary venous return. With the determinants for flow in patients with univentricular repair is pulmonary artery anatomy, pulmonary vascular resistance, and left ventricular and diastolic pressures. And they need to be very adequately or accurately assessed prior to doing a Glenn. And you use any modality. You have to use echo, you need CAD, if you have CT or the MRI, whatever you require. But all these variables need to be very accurately assessed in patients prior to Glenn. And to see that your pulmonary arteries are confluent and they are good size. This is just echocardiographic assessments which I am talking about. Do you have any azygos? You just see, if you have in a subcostal view, you are not seeing IVC entering into the right atrium and you have some blue flow going up. Make sure that whether you are dealing with IVC interruption with azygos continuation. And that needs to be carefully assessed on echo prior to bidirectional Glenn. This is a suprasternal view. Here two SVCs. They need to do bilateral bidirectional Glenn, and this information has to be accurately conveyed to the. And whether there are any additional aortopulmonary collaterals, because that again becomes an excessive pulmonary blood flow situation, and those collaterals need to be embolized prior to a bidirectional glention. As I said, 1 minute. This is again, I'm just showing an example on of I don't know whether it will work, but it's okay. Whether this is a restrictive bulboventricular foramen, this is a double inlet ventricle, this is the aorta coming, this is a bulboventricular foramen which is restrictive. So restrictive bulboventricular foramen is a high risk for future Fontan completion. It will cause subaortic obstruction and increase in LV hypertrophy and increase in the LV and diastolic pressure. So those things need to be very, very carefully assessed before planning a bidirectional. And many times when we do a Glenn, there are some additional surgical procedures which need to be done. It's a ligation of azygos. If there is a distortion of the pulmonary artery because of prior aortopulmonary, we need to do a pulmonary arterioplasty. If the AV valve is abnormal and is severely regurgitant, especially in patients with unbalanced AV septal defect, there is a high chance that AV valve may not be normal and there is a significant regurgitation. We may have to repair at that stage. Is there any accessory pulmonary blood flow like aortopulmonary collaterals that need to be taken care of? And as I said, repair of systemic outflow obstruction like restrictive bulboventricular foramen, if at all it is there. So in addition to doing a bidirectional Glenn in this situation, if there are any other variables which have been left, they need to be taken care of while doing a Glenn surgery. So this is as you know, it's a classical, not classical, it's a bidirectional Glenn shunt. Your SVC is anastomosed to the pulmonary artery. Now, post-Glenn assessment, you know, SVC is directly anastomosed to the right pulmonary artery. We have to, in the post-operative follow-up, we have to image it in the suprasternal short axis view, see to it that you have a smooth flow from the SVC into the pulmonary artery. We have to use very low velocity scale and low wall filter setting, and it should show biphasic low velocity forward flow signals. So we need to see the flow across the Glenn anastomosis. Is there any pulmonary artery distortion? Because sometimes you may see some flow acceleration, and a mean gradient of more than even 2 millimeters is very high in this kind of a situation. Is there any pulmonary artery distortion at that particular site? Are you seeing any decompressing vein? Because these are very important, and you know, especially after Glenn, if your oxygen saturations are very less. I always say that what are the oxygen saturation which you expect in first year of life after Glenn is around 80%. But if you have a child with a significantly low oxygen saturations of around 50% or 60% following Glenn, so there are certain things which you really need to think. One is you know that you may have pulmonary AV malformations because of loss of hepatic factor. The second one is if your Glenn pressures are high, your pulmonary artery pressures are high because of the high PVRI prior to Glenn, you see a decompressing veins coming from the innominate. They go into the IVC, and from the IVC go into the systemic circulation. So if you have significantly low oxygen saturation after a Glenn shunt, think about pulmonary AV malformations. The treatment of pulmonary AV malformation is you have to complete a Fontan. Second thing, if you have a decompressing vein because of the high pulmonary artery pressures, it can be due to pulmonary artery distortion. We need to correct that. Or you may have increased pulmonary vascular resistance because of anything, because you may have obstructed pulmonary venous return repair, or you may have done the pulmonary artery bind at a little later stage and your PVRI is still on the higher side. So you have to work on reducing the pulmonary vascular resistance aggressively by medications. So look for all those things when we see a post-Glenn evaluation. So these are some of the pictures actually. You see a very smooth flow from the SVC into the pulmonary artery without pulmonary artery distortion. I'll show you another example. You see the SVC, which is anastomosed to the RPA, but you see a significantly disturbed flow in this patient, and your right pulmonary artery is small in size. Now, just a short time, quickly go into a completion Fontan kind of a thing, a third stage or a last stage. We have different kinds of Fontan completions which usually are routinely done nowadays. Either it's a intra-atrial connection or a lateral tunnel Fontan, or a completion Fontan with the extracardiac conduit from right IVC to the main pulmonary artery. And this is this is a lateral tunnel Fontan in patients with a tricuspid atresia. You know, the original Fontan procedure was done in 1971 by Fontan, and the first Fontan which was done was actually a RAPA connection. The right atrium, a right atrial appendage was directly connected to the pulmonary artery, and this was the first Fontan. And there, you know, there are a lot of modifications. You really need to go into the history and the literature of Fontan. But the first Fontan done in 1971, this is a Francisco Fontan, and RAPA connection. And then there are multiple modifications. You have a lateral tunnel Fontan where right atrial tissue is used to do the conduit. And this is an extra, because, you know, as I said, I won't go into too much of a detail because there are a lot of modifications because of there were some pitfalls in the existing ones. And this is an extracardiac tunnel which is used to complete the Fontan completion. So usually your SVC, IVC blood goes into the pulmonary artery, lungs, again through the aorta, systemic circulation. So this is usually a Fontan circulation. So usually we need to generate a pressure in the SVC and IVC to push the flow into the pulmonary circulation. And you know, it is done without a hydraulic force. Therefore, systemic venous pressure, usually what happens in Fontan circulation remains more than normal, because otherwise it can't force the blood into the pulmonary circulation without a hydraulic force. And therefore, systemic venous pressure remains a little more, but at the same time, pulmonary artery pressure remains less than normal. So these are the two things which keep on happening throughout life in patients with Fontan circulation. And that is the reason I won't go into the details about the long-term problems, because that's another lecture we are going to have. But these are the basic things which happen in Fontan circulation, which is the problem for a long-term Fontan circulation. So Evaluation of preoperative Fontan again is a very important subset on itself. We need to see the features for surgical anatomy, morphology of ventricles, size of interventricular communication, size of pulmonary artery, ventricular functions. The ventricular volume overloading always is a major concern because it causes increased wall stress and myocardial hypertrophy. It has inappropriate changes in mass and volume. And ventricular hypertrophy actually is a major determinant of pulmonary blood flow because when you have ventricular hypertrophy, your end diastolic pressures are very high. If you have persistently elevated ventricular end diastolic pressure, it results in pulmonary venous hypertension. Eventually, it results in pulmonary artery hypertension, which determines your flow in Fontan circulation. So these are some of the really major determinants for Fontan failures in future, and therefore preoperative measurements of mass volume ratios are one of the very important things on echocardiographic assessment for Fontan. So assessment of risk factor: if you have pulmonary artery which is distorted, your pulmonary artery pressures are high, eventually your pulmonary venous resistance is above 3 Wood units, you have a significant AV wall regurgitation, ventricular function which is less. If you have ventricular hypertrophy, complex systemic and pulmonary venous return, and systemic outflow obstruction, these are the risk factors for Fontan completion. And all these risk factors, as I said, need to be assessed very carefully when we decide for a Fontan. As I said, you need any imaging what makes you satisfied. Echo is a must. All patients who go for a Fontan need a cardiac catheterization. Again, that is a must. In addition, if you feel that you need some other imaging like CT or MRI for anatomic delineation of the pulmonary arteries, pulmonary veins, systemic veins, you do whatever imaging to make yourself satisfactory to send these patients for a Fontan completion in future. You know, I won't go into it today too much detail, but you know, in single ventricle situation, always we consider left ventricle is a better ventricle because of its fiber arrangements, ejection fraction, and coronary artery reserve, because all these are important for ventricular function, which will reduce or control the left ventricular end diastolic pressure and eventually pulmonary artery pressure. And factors which influence this adaptation is age, feeling pressure, pulmonary artery anatomy, resistance, compliance, LV function, systolic, diastolic, presence of AV wall regurgitation, atrial dilatation, because that will lead into atrial arrhythmias. Again, that is the incremental risk factor for Fontan completion in future. I won't go into all this those criteria, 10 commandments, they are written in books, you go in detail. But as I said, amongst all these things, the most important thing is mean pulmonary artery pressure, pulmonary vascular resistance, normal LV ejection fraction. These are the criteria for a successful Fontan in future. So, in general, there are some incremental risk factors where you can just say where probable unsuitable, because we need to know it's not like that every patient has to undergo a univentricular repair for a Fontan completion, because if you do a Fontan, it's not going to work for a long time. We need to assess those risk factors very carefully, and these are, I feel, probably unsuitable candidates in initial evaluation on echocardiography or clinical evaluation. If you have a univentricular heart with pulmonary atresia, non-confluent and very hypoplastic branch pulmonary arteries, you need to see them in the beginning itself whether they are really suitable for a Fontan completion. If you have a single AV wall and severe AV wall regurgitation, we know that this AV wall will lead into progressive ventricular dilatation, dysfunction, raised LVDP over the period of time. You have a dilated ventricle with very poor left ventricular function, and you see the patient with univentricular heart with severe pulmonary hypertension who presents first time at a later age. That means ventricle with severe pulmonary hypertension you see at 3 or 4 years of age. there's no point in doing a pulmonary artery band to see that he may be a future Fontan candidate. So when you see these subsets on your initial evaluation, think carefully whether we really want to push them for a single ventricle because they are possibly or probably unsuitable candidates for a future Fontan completion. Okay, thank you very much. It's a big subset, and I think we need to have many more discussions and talks on this subject. Thank you very much.